so are our patients. So namaste once again to all of you. Before I begin, so I would like to show you the statistics of coronavirus, which is spreading. The graph is going up and up, and you can see the number of deaths which are happening on a regular basis. It's really a disturbing, but this is the fact. So we need to work together and act on it. I would like to show you the figure about the healthcare workers. You can see the healthcare workers, since we are the warriors, the patients have to come to hospital and the hospital as a team has to treat the patients. So you can see the statistics here. More than 20% of the healthcare workers who have been affected when the patients come to the hospital in Italy, and out of which there are several deaths have happened. So healthcare workers are unfortunately not spared because we are the one who are facing. We as a biomedical engineers or clinical engineers, though we are at a back end, we too are at risk. So I would like to get to the details of what need to be done by the biomedical team so that we are trying to mitigate the risk to an extent so that we and all the concerned people are safe. So let us concentrate on the clinical work in the hospital. You can see a clinical engineer working in the workshop, doing some servicing. Second picture is about a clinical engineer inside the operation theater and doing some maintenance work. Third is about a paramedical staff who is at the nurse station working. So I would like to know, this is a common scenario which would have been happening maybe 6 months back. There was no notice, but you can see here, the clinical engineer is not wearing the protective gloves. He is not wearing the mask. The engineer who is gone to the operation theater is not wearing the gloves. The paramedical staff who is handling the patient is using the same gloves, contaminated gloves, for operating the computer. Although she is wearing a N95 mask, she has got earrings. So all these are the flaws which were very, very common earlier. We never had known the importance of N95 mask or anything PPE as the clinical engineers, but the time has come wherein we need to get into the details. As the clinical engineers, we engineers go by the logic. So we need to know why we need to get into all these things. For that, we need to go to some microbiology, and you can see the various types of infection agents which are there existing. They are from a bacteria, they are from a virus, they are from a fungi, or they are from a parasite. So we need to look into these closely before we actually tackle the COVID issue. Infection transmission cycle is what I would like to briefly touch upon. As a clinical engineers, we being in a hospital, so we need to know certain things so that we are very well aware. Infection transmission cycle has the components, which is a disease organism, that is infection agents, reservoirs, mode of escape, mode of transfer, mode of entry, and susceptible host. Let us look into one by one. Disease organism, as I was telling in the previous slide, is about bacteria, virus, fungi, or parasite. Reservoirs for that is the people, equipment, inanimate objects, or water. Mode of escape for these disease organisms are excretion, secretion, or droplets. How they get transferred? Through contact, airborne, droplets, or vector-borne. What is the mode of entry to a patient or to a person? Respiratory tract, GI tract, skin, mucous membrane, or genitourinary tract. And who are the susceptible hosts? The patients who are immunosuppressed, like cancer patient, elderly patients, surgical patients, are the susceptible host. Now this infection transmission cycle is what we need to concentrate upon. How to break this cycle is something which we need to really look into. To break the disease organism, what we need to do is we have to decontaminate. We have to do a prompt treatment. We have to do a rapid identification of the organism. To get into the reservoirs, we need to look into the good hygiene condition. We need to look into the environmental sanitation, disinfection. To break the mode of escape, we need to again have a proper attire, hand hygiene, trash and disposal measures, control of secretion, excretion. To break the chain of mode of transfer, we need to again have hand hygiene, airflow control, disinfection, sterilization, proper food handling and isolation precautions. To break the chain of mode of entry, we need to have again aseptic technique, wound care, hand hygiene, catheter care. Finally, susceptible host. Again, treatment of the primary disease, recognize high-risk patients. One thing you can note here, a common, is the hand hygiene. Hand hygiene forms a major important point for fighting the infection transmission. Now coming to the COVID. The picture shows the size of the COVID virus. You can see the size of the RBC. You can see it is 7 micron, but the COVID is around 0.1 micron. So we are dealing with such a minute microorganism, which is basically spreading and affecting the human body. As said, corona is respiratory illness and primary transmission route is through contact to contact or through a direct contact through respiratory droplets. So which will infect a person by cough or sneeze. You can see here a picture of a droplets which is transmitting. The graph shows a size of the droplet in the x-axis and the number of particles produced. You can see a sneeze produces a maximum number of particles, size of the particles. And the other picture shows what is the distance traveled by each. So we all need to be clear that respiratory tract, lung is the part which gets affected if there is a COVID. And we need to ensure that we have a mitigation for addressing this. So again, going back to the infection transmission cycle. So the disease organism is a coronavirus, which is 125 nanometer or 0.12 micrometer. So decontamination, prompt treatment, rapid identification of the organism is what need to be done. Reservoir here for a coronavirus is people, equipment, inanimate objects and surfaces. So good health, social distance, environmental sanitation, disinfectants, sterilization is what need to be done so that the reservoirs are being curtailed. Mode of escape is droplets and secretions. Hand hygiene, trash and disposal, then secretion, then proper attire is what need to be looked into. Mode of transfer is through a contact and droplets. Airborne is there, but only during the aerosol generating procedures. Again, hand hygiene, airflow control, especially in the isolation rooms where there is a negative pressure is been there, disinfection and sterilization, proper food handling, isolation precautions, and a social distance of 1 meter need to be looked into. Mode of entry is through a GI respiratory tract. GI tract is also to an extent. Aseptic technique, wound care, hand hygiene, catheter care need to be looked into. Susceptible are the older adults, the people of any age who have a serious underlying medical conditions. So recognize the high-risk patients, treatment of the primary disease is what need to be looked into. So the infection transmission cycle can be broken if we look into all these aspects. So now let us go to a next step. These are the some of the awareness campaigns which have come from the Ministry of Health. So it spreads through droplets, through eyes, nose, and mouth. Okay, we need to maintain a social distance of minimum 1 meter. So there are some of the items which are frequently touched. We need to take care of those, especially in the common areas. As I was telling, the hand hygiene is the one and most important aspect which we need to look into. You can see a picture of washing the hand with a soap and water, and also through a hand sanitizer, which is very much available in the hospital or healthcare environment setup. These are the do's and don'ts again given by the Government of India. Greet the people without a social contact, physical contact. Namaste is what we do in India. Maintain a social distance of 1 meter. Wear a reusable or the mask of a different the filtration level. Maintain a respiratory hygiene. Hand washing should be done frequently. Clean and disinfect the things on a regular basis. Certain things to be avoided: unnecessary travel, touching the eyes and nose and mouth, and sitting together, and also moving in the crowded places. This is something which we know because we have been bombarded with the information for last several months. But as a precautions for the clinical engineers, we need to look into other aspects. So there are standard precautions which need to be taken by any person who is working in the healthcare setup. Standard precaution is to apply all care of activities regardless of the suspect or confirmed infection status. The protocol includes hand hygiene, use of the gloves, gown, mask, ear protection or face shield depending on the anticipated exposure, safe injection practice which need to be maintained, and finally, which I'm highlighting, equipment or devices in patient care area which is likely to be contaminated must be properly cleaned, disinfected or sterilized for a reusable equipment before used on the next patient. So we'll be concentrating more on the medical equipments. Before we do hand hygiene, when the hand hygiene has to be done. So there are 5 moments which are there: before touching a patient, before clean or aseptic procedure, after body fluid exposure, after touching the patient, and after touching the patient surroundings. Now, as a clinical engineer, we will be mostly involved in 5th, that's after touching the patient surrounding. When we go for a maintenance activity, either a preventive maintenance or a breakdown in a patient care area, there is a most likely that we will be touching the patient surroundings. So hand hygiene has to be followed. WHO comes with a standard hand hygiene practice guidelines, so which has been shown here. We need to adopt it sacrosanctly. So hand hygiene is something which should be done, and PPEs, which I'm going to cover, cannot replace hand hygiene. Hand hygiene is must, which need to be looked into. Besides the standard precautions, there is something also called transmission-based precautions. These are the added measures to prevent the spread of disease from a patient with a known or suspected disease. So on the top of the standard precautions, the transmission-based precautions need to be taken into consideration. There are 3. One is a contact precautions. Second is a droplet precaution. Third is a airborne precaution. In case of a COVID, contact precaution and droplet precautions are something which we need to really look into. This is a typical picture which has been put on the patient area. So based on the type of the transmission which is expected in that particular area. You can get all the details about this in the below mentioned website, which has been given by the Government of India. Now the precautions further are basically personal protective equipments. Personal protective equipments are protective gears designed to safeguard the health of the worker by minimizing the exposure to a biological agent. Now these PPEs, which most of us are aware, because now in the hospital, this is one of the important thing which everybody is talking about. There are various components: goggles, face shield, mask, gloves, overall gown, shoe cover. All these things are to be used based on the risk level. Again, you can visit the website of the Government of India and see when and which PPE need to be used. As I have pointed out, based on the risk in the various areas, what a clinical engineer need to wear as a PPE. As you can see, in a non-COVID ward area and in a clinical engineering workshop, risk is low. Triple layer medical mask and gloves can be used. Where in the high risk area, like an operation theater or a COVID lab where the samples are processed, full component of PPE, which has been mentioned above, need to be used, where aerosol generation process are anticipated. But please refer to your hospital infection control policy on PPE and adhere accordingly. But this is just a guidelines which has been derived out of the Ministry of the Health, which has been followed. Now, precautions for infection control and prevention for donning and doffing. Now the PPEs are there. How to wear and how to unwear is what is being covered in donning and doffing. If the PPEs are not being used properly, then there is still possibility of a contact or a droplet exposure. So we need to do it in a very methodical way. There are various steps followed by the various organizations. Okay, but the best way to do these steps is follow the buddy system approach. A buddy system approach is where two or more persons formed among the deployed hospital staff who share the responsibility of his/her partner's safety and well-being in context of approximately donning and doffing of the PPE, maintaining the hand hygiene, and taking the requisite steps to observe the breach of the PPE. So what happens is, this is the typical donning of the PPE in our hospital, wherein there are 11 steps are there. Hand hygiene, then head cap, then wearing the N95 mask, then the shoe cover, like this. So when a person is going to don, for example, a clinical engineer is supposed to go to a ICU where the COVID patients are taken. He can go in the donning area where he need to change. His colleague will be there. He will read out the step and ensure that other person who is supposed to enter is wearing it properly. So in this way, no step is being compromised, so that when a person is going with the PPE, he has a full protection assured. Same thing can be done at the doffing. So donning and doffing are very, very important steps which need to be looked into. So these are something which has to be practiced on a regular basis, so that when a real situation comes, we are 100% sure that there's no exposure which happens. This is something which out of our practice, we have noticed that suppose a situation arises that in a hospital where we are working, we have a mechanical ventilators. The ventilators all are in use. Suppose a COVID patient who is in an ICU, the ventilator is not working. The concerned person, nurse or a clinician, will call the bioengineering department or clinical engineering. He need to go and ensure that the call for that is being attended in a very short time. This can only happen when we perfect the skill of donning. But if we don't practice, it takes almost 8 to 10 minutes to don. So we don't know what is going to happen when there is a serious error is there and no technical person is around and there may be a compromise to the patient safety. So my request to all the clinical engineering community is to ensure that a regular mocks of donning and doffing. Doffing is also very, very important because when you are doffing, it has to be done in a proper way and it has to be all the things which have been taken out should be put in a proper biomedical waste segregation. So please ensure that donning and doffing is being followed properly and practiced. Now coming back to our subject, medical devices. Medical devices are classified various ways, but for the sake of infection control and prevention, we classify into 3 ways. One is visibly contaminated medical devices. These are the devices which are soiled with the blood, feces or urine. Example is a centrifuge machine. Example may be heart-lung machine. Example can be blood gas analyzer. Second one is very likely to be contaminated even though no visible, like the dialysis machine can be one of the example. Third one is any other device which is not contaminated, not very likely to be contaminated. You can see a picture here, ICU setup wherein infusion pumps and bedside monitors are there. So they may not directly be contaminated, but there is a possibility as we are not able to see the contamination through a naked eyes. So we need to do a proper cleaning and disinfection. So in this way, the medical devices are being classified into 3 different classes and the cleaning and disinfection has to be done based on the type of the medical device which we are talking about. As you know, there are some studies wherein coronavirus can survive up to 3 to 7 days on plastic and stainless steel, both of which are commonly found in the medical equipment. So it's very, very important that cleaning and disinfections are being properly followed and we know the implication of not following it properly. This is the website through which the information can be sought. Now let us get into a cleaning and disinfection. Though the cleaning and disinfection is not per se done by the clinical engineer, but it is very, very important for a clinical engineer to emphasize on cleaning and disinfection for the sake of all the paramedical staff and for them also, because they also attend the medical equipment and they get the equipment for servicing at the workshop. So they need to know what need to be done for the cleaning and disinfection. So let us understand, because we use this terminology cleaning and disinfection regularly, but is there any difference? Yes, there is a difference. Cleaning is a process of physical removal of the foreign material, including dust, soil, organic material such as blood, secretion, excretion, and microorganisms. It can be accomplished by water, detergent, and a mechanical action. It is not going to kill the microorganisms. So please note that cleaning is not the only way to give the equipment back to the user department or to be used on the patient. Cleaning is prior to the disinfection or sterilization. So in a cleaning, there are 5 things which are very, very important. Contact time, temperature, concentration, mechanical action, how much pressure you exert so that a stain is going to be removed, and a pH of the chemical. So the disinfection is done on the top of the cleaning, but it cannot be done alone. First, you have to do a cleaning, a process of inactivation of the disease-producing microorganisms used on inanimate objects, like inanimate objects are medical equipments, and surfaces usually involving chemical, heat, or ultraviolet lights. Most of the common disinfectants are quaternary ammonium compound products or sodium hypochlorite. So as per the CDC guidelines, For a porous surface, sodium hypochlorite 1:10 dilution in water. For a non-porous surface, sodium hypochlorite 1:100 dilution of water is preferred. Again, disinfection is based on the type of the equipment. So for each of the equipment, I cannot generalize that the same thing need to be done. So the following website can be referred, wherein there are various different types of the disinfectants which can be used, including the brand names which are being mentioned. So the cleaning and disinfection steps, as I was mentioning, clean the surface to remove the visible surface soil and dirt for a medical equipment. Apply appropriate disinfectant and allow the surface to remain wet for some time, specific time. Now, what is sterilization? Sterilization is a process of killing all the microorganisms, including vegetative bacteria, viruses, fungi, and bacterial spores. So the sterilization is basically done through the equipments like a steam sterilizer, ETO, or plasma sterilizer. Decontamination is a process of reducing the microorganism to a safer level. So decontamination is accomplished through a cleaning followed by appropriate disinfection or sterilization procedure. So when we talk about decontamination, we are covering cleaning of the medical equipment as well as disinfection of the medical equipments. Sterilization of the medical equipment basically is for the medical devices, the sterilization is being done. Like for the instruments, the sterilization is being done. For the medical equipments, basically disinfection is what is being followed. Now let us get to a scenario where the ICU scenario where the patient is lying and all the medical equipments which are necessary for the patients are being connected. You can see the picture here. The equipment gets soiled with a blood or body fluid, secretion or excretion, which is likely to happen in this environment. The soiled equipment can transfer the pathogens to the other patients or staff or environmental surfaces. That's why we are talking about cleaning and disinfection. So the reusable equipments, cleaning and disinfection is used before the other patients are being taken. So that's why we need to ensure that cleaning and disinfection is being done. But it cannot be generalized, as I was telling. It is based on the manufacturer's recommendation or the facility policy which is being dictated by infection control team. So the single-use items can be discarded. So in the case of a coronavirus, wherever possible, single-use devices which were used multiple times can be discarded, considering the nature of the risk posed if we are going to use it again. And non-critical items like NIBP cuffs or fingertip-based pulse oximeters can be used once. So not necessary that it should be used on one patient to other. So this is a typical chart of cleaning and disinfection of various equipments used by our hospital based on the practices which are being followed as per the infection control. I am not prescribing or suggesting this is what need to be followed, but a visualization from your hospital for various equipments and what is the frequency of cleaning and disinfection can be displayed at the ward and ICU and in the OTs so that the people can follow it. Very, very important thing which need to be looked into is a traceability. When we do an audit, we often find the people may not be following the process of cleaning and disinfection based on the frequency. So within now COVID time, so as you know, it's a contact based and a droplet. So it's necessary that we sensitize the team, nursing staff or a paramedical staff to do it exactly as per the protocols given by the manufacturers, and the infection control team and a quality department can regularly audit so that the process of cleaning and disinfection for the medical equipments are being maintained. So this is the way in which the cleaning followed by disinfection is happening with the sodium hypochlorite solution in our hospital. So as I was mentioning, cleaning and disinfections are not restricted to one sort of equipment. All the equipments, cleaning and disinfection has to be done. So you need to get the protocol of cleaning and disinfection from the service providers, very, very important, and follow the norms. If you don't do it, if you do something which is not been prescribed by them, so it may void the warranty or the contract. So please ensure that cleaning and disinfections are being followed on a totality based on the OEM's norms. Similarly, for the pictorial method for the syringe pump, which has been shown here, same way the process is to be followed the way it has been mentioned. So it is necessary for a clinical engineer to ensure that as a part of the acceptance of the medical equipment, cleaning and disinfection process to be understood from the service provider, and same thing to be informed to the infection control team and other nursing team, so that on the ground it is being practiced. Another important thing which I would personally tell our community is, whenever the preventive maintenance is happening, so please ensure that the cleaning and disinfections are being followed. If there is a quarterly preventive maintenance is happening, so cleaning and disinfections are being followed by the service provider the way it is. And it should be a part of the orientation for the nursing team and the paramedical that cleaning and disinfection protocols are being followed the way it is being prescribed by the manufacturers. Now, good practices which need to be followed by the clinical engineer. ECRI describes some of the good practices which need to be followed by the clinical engineers. I am trying to summarize them with some additions based on the COVID. As mentioning again and again, telling hand wash routinely, especially hands when they are soiled, when we are doing the servicing, after handling the soiled equipment, after removing the protective gloves, before eating, before leaving the hospital, and at the workplace, maintain a social distance. Do not eat, drink, smoke, or apply cosmetic within the hospital. Wear a safety dangri suit. This is something which I think we need to follow, because if we come in our street clothes and move around in the various clinical area and again go back, so there is a possibility that we are getting the infection from outside. From the hospital, we may be spreading. We are the warriors. We should not be the one who will be spreading. So it's better that we use the maintenance suits, so which can be washed frequently in a hospital environment. We need to wear the gloves when touching the contaminated objects, but very important, do not touch the clean items, which I was showing in my earlier slide, after doing the servicing with the contaminated objects like doorknobs, telephones, etc. with the soiled gloves. Do not rub the eyes or other mucous membranes. Follow the biomedical waste segregation process, which is also very, very important. So the other things which a clinical engineer need to follow is adhere the standard and transmission based precautions as per hospital SOP. I have explained earlier about standard and transmission based precautions, but we need to follow it as per the hospital SOP when entering and leaving the working area that pose a special infection control problems like a operation theater, lab, or isolation rooms. Treat the contaminated any device that is visually soiled with the patient, even if it is dried, because you will not see through your naked eyes. So please ensure that these are being done the way it is supposed to be done for cleaning and disinfection. So in general, the devices for any area where the body fluid is spilled is something which need to be looked into. Dialysis devices or the equipments in the OT which are above or below the surgical tables, or any handheld items, clinical lab equipments, surgical instruments, blood warmers, etc. are to be treated as a contaminated devices. So clean, disinfect or sterilize medical devices before inspection or repair, and again returning them to the patient care area. So what we need to take care is cleaning and disinfection has to be done whether in our clinical engineering workshop or in the clinical area as per the norms which is being given by the service provider. Now, the topic which I'm touching today is about 5S and risk assessment. The background for that was this, which we talked about, basically on the infection prevention. Why we need to organize and keep the environment clean in the clinical engineering. By now you might have understood, and you know earlier, that the clean environment is very, very important for the safety of ourselves. So it will help us to enhance the safety. The clean environment and organized environment will improve the time management. It will improve the quality, overall quality of the service provided by clinical engineering. It has a visual control so that we'll quickly look into the things, and customer the response is going to enhance. So that's the reason why we need to create a clean and organized environment. How do you do this? This is done with the help of the 5S. 5S is basically the foundation for total productivity maintenance. This is basically a concept which has come from Japan, wherein the maintenance is to be looked through the eyes of our production, and how well we manage our medical equipments and their maintenance will help us to get into the more organized way of putting the things. So it has 5 steps. One is a sort, second is a store, third is a shine, fourth is a standardize, fifth is a sustain. So to give a pictorial, before the 5S, a department may be like this. Post 5S, which has been implemented, it looks more organized. So let us get into each of the S to understand what is that particular S is all about and what need to be done. First one is sort. Sort basically says, when in doubt, move it out. Let us see what exactly it means. It talks about organizing the things. Objective is to decrease the waste and loss. And you can see a picture before the sort in one of the area in our hospital. This is how it looked like. This is what is the picture which has been taken. Now you can see how the sort is to be implemented in a hospital. You can see a flow chart. As an engineers, we are well versed with the flow charts. So you can see a hospital wherein our workshop need to look into identify all the items which are there, make a list of all the items and see whether they are going to be used or not used. If they are going to be used, put it in one side. If thing is not being used, it should be put in the other side. So the other side is called as a red tag. So all the items which are not used are being put in a red tag, which has been shown like here. Then you can decide making a list and discussing with your head of the department whether that item need to be still used or that need to be condemned or discarded. The item which is going to be used, for example, a soldering iron, for example, an instruction manual or a service manual. So they need to be kept in one place, as I was telling you. Then you can put whether it is going to be used on a daily basis, weekly basis, or a monthly basis. So then you can put a label on those things. Like for example, the screwdrivers or a soldering irons is going to be used on a daily basis. Whereas a service manual may not be used on a daily basis. And the warranty card may be used once in a while. So these can be segregated as a day wise, week wise, and a month wise. So if we do all these things, then we are going to cover the first stage of our 5S. This is very, very important because you are looking into all the items which are available in the clinical engineering department. You get into one by one to see whether it is to be used or not to be used. Accordingly, you need to segregate. So after the sort, you can see a picture how the changes have happened in that area. So we have this here, you can put a red tag indicating that these needs to be taken out. So unnecessary items which are there are being taken out. This will help us to save our space and also to ensure that right items are only being kept. We often complain that our space is a constraint. Biomedical engineering, unfortunately, has a space is a constraint because most of us are been either in the basement or in the engineering area wherein we need to manage. We are not in a, being a support department, we need to manage our space very judiciously. So this is how we can do in a clinical engineering department. Identify all the items in the workshop, the list which has been given, all the defective items to be taken out and dispose it off accordingly. Next is a store or set in order. Here, neatness is something which need to be looked into. It will increase the overall efficiency. So before the store or set in order, this is how the workbench looked like. This is how the items were kept. In the store stage, what we do is whatever items which have been used in the sorts stage are to be organized in a proper way. So there are items which are to be used daily use. There are weekly and monthly, which I said. So we need to ensure that they are being kept in an appropriate place so that they can be easily be accessible. Here, the point is we need to ensure that they are being kept in a right place so that a travel time to get it or movement of that can be avoided. A spaghetti diagram, which has been shown here, is something which need to be used as a tool so that we can arrive at a right layout of our workshop so that less waste or muda happens on account of transportation or motion from the people. So after the store, this is how the department looks like. Next step is, you can see here, visualization is very, very important in the stage which in the store. All the areas are being marked and wherever possible label is being put. You can see there's the items which are being kept and we know which item to be kept where. This is very, very important because our departments work in some of the hospital 24/7. We are not there for all 365 days. If something is to be a tool which is a common tool, it has to be kept at a right place. Otherwise, other engineer who comes, he will keep on searching for it. So this can be achieved in the store stage. Now you can see this item is being taken out from there. Immediately we'll get to know that this item is not there so that we can immediately keep it back. So the sort and store will help us to ensure that the right items are being there in the department and they are being kept in a proper way. They are being identified and the visualizations are being maintained. So in a clinical engineering environment, keep the daily items in one place, keep the weekly and monthly items in a particular space, like for example, service manuals, mark the locations like the placement of the tools, kits, and mention the quantity. As you can see, you can see here, mark the location of placement of the DC power supply, calibration devices, CRO, mark the location and mention the quantity of the spare placement, mark the location of incoming defective equipments, and the one which has been serviced. All these things are being properly visualized so that there is no confusions. We often find there are multiple infusion pumps which are been there in the clinical engineering department from various departments. The department people come and say, I need back my infusion pump. We are not sure whether it's been repaired or not because they are all been kept in one place. If we follow this proper storage, so we are clear that what is been repaired, what is not been repaired. Next stage is shine. So we need to ensure that the items, after they have been put in a right place, are being cleaned on a regular basis. Objective is to observe, inspect, and correct. So before the shine, this is how the department looks. In the shine, basically, we will ensure that the cleaning happens on a regular basis. So there is a schedule for the cleaning which has been maintained, and there is a task which is being given to each of the stakeholder so that the cleaning happens. You can see here a schedule which has been prepared, okay, for the various areas and when it is to be done, and a responsible person. So the shining is something which not necessarily will have to wait for the housekeeping department to come and clean. Certain things which cannot be done by them, for example, our workbench need to be cleaned by the clinical engineer. So we need to ensure that this has been done at an appropriate time so that it has been kept spick and span. So the shine is something which need to be done on a regular basis, and there has to be systematic scheduling which need to be done. By doing so, we'll be able to maintain the things in a proper way. So these three things are the foundation for the 5S. But to achieve this foundation, we need to do a lot of groundwork. We need to basically do our change in our mindset. A culture has to be set wherein we need to organize ourselves. This has to come from the top, from the HOD to the down the line people. This is how post-shine the department looks. Although you cannot see in the picture, but definitely I must tell you that post the shine stage, the regular cleaning had made a lot of difference. We felt like visiting the place on a regular basis. So shining basically is being done on a regular basis. Frequency of timing of the workshop should be fixed. It should cover all the areas, including the false ceiling, inside the false ceiling, on the top of the cupboards, and even the waste bins. Next stage is standardize. As I keep on telling that the hospital works in 24/7 environment. It's not necessary that a same person is going to continue. And if the other person does not get the right things at a right time, it's a waste. And we need to ensure that these things are being done. Although it has been put in the store stage, but if it is not been standardized, then it's very difficult for us to search for it. So we need to ensure that a standardization happens. So there are various tools which are being used in the standardization. One of the tool is basically to ensure that the schedule is being done as a 5S job cycle chart. 5S job cycle chart, basically, as it can be seen, all the jobs are being put here in a chronological order. These are the various stages: sort, store, and shine, and which step what is to be done and who is responsible for this. This need to be done and it should be followed on a regular basis. So you can put all the steps which are there in your process and see that when that need to be done. And also we need to compare with the last time when it has been done and what is our score. So this will ensure that standardization phase is been maintained. Standardization is one of the toughest thing because we tend to go back to our old practices, but with the proper our 5S job cycle chart, and the 5 years maintenance level, we will come back to the stage which we want it to be there forever. So after the standardization, whosoever comes, whenever they come, so they will get the right things at the right place. So you can see here, you can relate it with your area, that the tools which are been there are being put in a various slots. So if it has been standardized, so it's very easy for everybody to follow. And if it is not been done, it has to be done on a regular basis, so that somebody checks it and ensure that these have been put, so that there is a variability has been avoided. So we'll get a right tool at a right time. Last but not the least is sustain. So sustaining a practice is all about discipline. Although standardization we talk about, but finally it's a discipline from the top management to ensure that things are being followed, to maintain and train. So before the sustain, this is how the picture of the department looks. And in the sustain, what we do is we do a slogans for the 5 years. We wear a 5 years posters. We do a 5 years exhibitions across the hospitals, so that the 5 years campaign is being maintained and practiced by the various departments. So as a clinical engineering department, so I would urge all of you to use this simple 5 years technique, so that things are being properly organized and you use judiciously your space. And more importantly, cleaning and disinfections of the tools and the equipments happen as a part of this process. So this is what looks post the last stage, that is standardize. Now this is the picture of my visit to my CCOM hospitals in Japan, wherein you can see the biomedical engineering workshop. So it looks like a showroom for me. When I went, I was shocked to see. I was wondering, this is something which is a procuring area, but it's a service area. All these things are being organized. They have been put properly labeled, and things are being kept. So whether it's the infusion pump, ventilators, even the calibrators. So this is something which, as a practice, if we do it, then we will be able to do more efficiently. As it was told earlier, a safety has been followed, and our customer, the nursing team or a paramedical, will be happy because we take care of the equipment properly. Now, as a part of the TPM, so we need to ensure that autonomous maintenance is being properly done. Autonomous maintenance is a need of an hour. The reason is we cannot go on a regular basis to a COVID area where the patients are there as a clinical engineer, as a part of the walkthrough inspection. But at the same time, we need to ensure that the equipments are maintained. How do we do it? We train the nurses or technicians so that the small maintenance activities are being taken care by them. So you allocate, train the people so that smaller maintenance activities are being done. So this will help us, clinical engineers, to free from the regular activities. For example, if there is a SpO2 probe is being dislocated, what the normally sister will call, they will see the alert and they call the clinical engineer. Clinical engineer goes and sets it right and comes back and says that the work order is complete. But this is a very regular. If we can train the nursing staff, why can't they do it? If they see the error code and see, okay, can this be done? If we train them, the clinical engineering team can take care of major activities and they can plan the major technical things. Proactive risk assessment can be done by them. So the autonomous maintenance is something which need to be adopted, and it's a need of an hour right now with the COVID environment. We cannot wear with a PPE on a daily basis and go on around. So nurses and technicians should take a responsibility of the upkeep of the equipment. We have to ensure that they do an initial cleanup of the equipments at the inaccessible regions, which has been left out. You can see in most of the hospitals, the areas just behind the equipments are being left unnoticed. The reason being, the housekeeping department people, they will be scared to touch the cables. The technicians are not much bothered about the or nurses. So it's all depends on the clinical engineer. And once in a while, once the preventive maintenance happens, the cleaning is been done. So even if it's a area which is like an operation theater where the HEPA filters are being used, but still you find the equipment's the dusty environment because the cables have been not been touched by anybody. If the autonomous maintenance has been done, so these are being taken care by the nurses or technicians themselves. So they are being trained how to act on the alerts so that certain first level servicing can be done by them, and then later on they can take the help of the clinical engineer. So this will help like the activities like a regular battery charging, replacing of the filters, and taking care of the accessories are being done as a part of the autonomous maintenance. Now the second portion which I would like to touch base upon is about hazard identification and risk analysis on account of COVID. As we saw, what are the ways through which we can organize our workplace. But still in our process, there are possibilities of risk which are there. So before that, let us understand what is hazard and harm. Hazard is a potential source of harm. As you can see here, a clinical engineer touching the equipment without the gloves. Okay, if it's already been the soiled and it's been used on the compromised patient, so it's a hazardous condition for a clinical engineer. What can be harm? Harm can be a physical injury or damage to health of a person or a damage to property. In this case, it's not a damage to property, but definitely a damage to the clinical engineer. So how to assess it? To assess the hazard, so there are grades which have been given, low grade to high grade. Severity with which the critical may be the severity is a death of a person who is touching the equipment. Low is so he has been admitted. So then second thing is likelihood. How likely the particular hazard condition can happen in our setup. So this is something which we need to look into. So again, the grading is been provided. So the grading is again from 1 to 5. So the risk matrix which has been defined down is a combination of severity of the hazard and a likelihood of the hazard condition. So if we understand the severity of a particular process based activity and what is the likelihood, then we can get to the score which is called as a risk matrix score. So let us look into what are the risk matrix scores which are mostly happening in a clinical engineering setup. So risk is basically a combination of probability of occurrence of the harm and a severity of the harm. Risk matrix is what I have told, which has got two components: severity of the risk hazard condition and likelihood of the hazard condition. And you can see the color coding. Green is okay zone, yellow is something which can be reduced, looked into, and red is something which need to be definitely reduced to avoid the risk. Now let us get into the clinical engineering processes. So in the clinical engineering, I would like to take few so that you can understand what I'm trying to tell you. For example, the equipments, as I told you, can be divided into 3. Soiled equipment, visibly contaminated, or very likely to be contaminated, or the one which is devices which are not contaminated. Now let us talk about a visibly contaminated. Let us take, for example, suction apparatus, a suction jar where the suction happens. So if the suction unit with the jar comes to the clinical engineering department, okay, without proper cleaning, so what may happen? So there is a severity is there. Okay, so if it is being used on the patient who's asymptomatic, but later on he may turn out to be a COVID. So there is the severity is there. The severity score is been serious. We have put as a serious. And what is the likelihood? Likelihood of this condition is very high because currently there is no cleaning and disinfection happening at a clinical area. They are this suction machine used on the patient. It is not functioning. They simply sent it to the biomedical engineering department. So if you see this, the score will be 4 and 4. 4 is a risk is very high in a COVID environment. Likelihood is very high because there is no proper practice. The risk matrix, it is 16. So this is a serious issue. Similarly, we can take another. If a clinical engineer is not using properly a PPE, and if he is going into the COVID area, so then again, there is a possibility of severity is very high, and a likelihood is also high because currently the clinical engineer has not practiced properly. So he has only seen the presentation, he has only seen the other people wearing, but when the real condition came, he was wearing, but it was not proper. So then the risk is very high. So, so if these things are there, what need to be done? So we need to reduce or mitigate the risk. So till we don't go into all the steps, activities which are related to clinical engineering department, and we are not able to see the risk score, we will not be able to understand what is the implication of it. So it's very, very important for us to identify our process or hazard conditions or which are part of the processes and give the potential injury which is going to happen based on that. For example, if improper usage of the PPE, so infection transmission from a contact or a droplet will happen to a clinical engineer. Okay, and the score is very high. So if the score is very high, we need to ensure that we have to come with some mitigating factor. You can see here that we'll take the first example, the soiled equipment visibly contaminated. So as we saw, the score is 16. Okay, the cleaning and disinfection at the clinical area is currently there, but it is not proper. So what need to be done is an additional cleaning and disinfection instruction to be followed, and the people are been knowing about it. And for example, in case of the suction jar, it is been ETO'd, then it has been brought to the clinical engineering department. Then what will happen? Our score of severity will be the same, but likelihood of infection transmission is being reduced from 4 to 2. Again, refer the matrix, will get a score of 8. So the score of 8 is a sort of an okay. It's not in a danger zone. Similarly, I'll take another example, which I have told earlier. Improper usage of the PPE. Here, the score was 16. So the PPE was unavailable at one place, and they said, it's okay. What is going to happen? It's okay. We'll get into. Or other people or team was not aware. Here, we are training the people and sensitized. Regular audits are being done to see the PPEs are available. By doing so, we are able to again reduce the likelihood of the risk to 2. Severity will still remain same because the severity of the contact cannot be reduced. So the score is 8. So in this way, what we are going to do, we are going to reduce the risk level from the earlier to the next after putting the additional control measures which have been put. So you can see here, some of the control measures have been already put, some are yet to be put. So you need to, as a biomedical engineering team, need to identify all your hazard conditions and see what is the potential injury or health illness because of this, and come with the rating and come with the control measures so that the rating is being reduced and a mitigation is being done. And finally, you sustain it. In this way, the risk is being identified and risk is being mitigated. So this is a picture which shows the all the hospitals team members are being told whenever outside service provider comes, they need to disinfect their or the cleaning agents or their tools through our disinfectant. So this is being followed for each of the service provider so that they will not come with the tools which are being used in other hospital where it might have been used on the COVID suspect patient and comes to our hospital and try to do servicing. So this can be set up within the hospital. Similarly, you can do one more thing. You can identify your equipment which is being in the part of the COVID area, so that you know that there are some movable equipments can be moved from one area to other, but restrict the COVID zone where the equipments are not been moved. They are been confined to that place so that, and they have been properly identified. Whenever this equipment comes outside, immediately people will identify it and see to it that it goes back to the area, barring the transport monitors or transport ventilator, which have been taken along with the patient and been brought in. Kaizen is something which can be followed. Kaizen is continuous improvement. So Kaizen is something which has been done, can be done on a regular basis by the clinical engineering department. Here you can give an example. The anesthesia intubation where the high aerosol generation is possible. So we put a chamber, so which has been done so that the aerosols are been here. Intubation can be done properly by the anesthetist. Another good practice can be when there's a COVID suspect patient is there, you can close the equipments with a plastic cover so that the equipments are being protected and later on the plastic cover is been disposed of. Then still you need to do cleaning and disinfection, but the level of exposure is reduced. The preventive maintenance has to be done on a regular basis by the people so that the people are trained to get into the various areas on the COVID environment, and they are used to do a servicing with the full PPE. This is a picture which has been taken where the clinical engineers are actually doing the servicing of the equipment in a COVID area. So please see to it that you are being well versed with this. You carry the tools, all the tools, and do a proper preventive maintenance or the calibrations or breakdown the way you use, like when you are not using the PPE. The practice will only make the clinical engineer perfect on this. Disinfectant mat is something which is being suggested in most of the hospitals because you have a transportation equipments, like a transportation, the trolleys, stretcher trolleys are there, wheelchairs. If a disinfectant mat is there, the wheels get disinfected. So in a nutshell, the takeaway message for a clinical engineer with respect to COVID-19 is go through the infection control program training, which is very, very important for us. Do know when, what, and how to use the PPE. Organize your work area properly using the 5S technique. Obtain the risk score for critical activities, as I was telling, and come up with the control measures. Ensure maintenance tools are disinfected for both in-house and service providers. Identify COVID-19 area equipment with a proper tag. Train the staff on cleaning and disinfection of the equipments as per the manufacturer guidelines. Cover the equipment with the disposable plastic covers while in use in a COVID area. If feasible, keep the additional accessories, equipment, and service tools in the COVID area so that the immediate response can be taken in the clinical area itself by the nurse or technicians. As much as possible, use the electronic document, especially in the COVID area. Don't carry the service report, don't carry the manuals. Let it be, the electronic mode can be used. Let the user be taught to concept of total preventive maintenance so that they can fix the problem themselves. And train the staff on a donning and doffing on a regular basis and monitor this, including the time. And let the mocks be done on a regular basis so that we know what are the gaps which are going to happen in our maintenance practice. With this, I would like to conclude with a Subhashita, which says, good health is the greatest blessing. Health is means of everything, which has been written in Sanskrit. Thank you. Dhanyavad.
Thank you so much, sir. Thank you so much for this wonderful, informative session. In fact, there have been so many messages from the delegates, thanking you for this today's session that you have helped them with. So there are a lot of questions, some of them which you have already answered, but I would just like to repeat for the benefit of the delegates. So, sir, do you mind? Can I take 5 minutes of question and answer?
Sure, sure.
Okay, the first question that Mr. Naresh has asked, decontamination of medical devices can be done only externally, but what about inside? Like, for example, in case of laboratory hematology analyzer, if a COVID-19 positive sample is processed, how to decontaminate the machine from inside?
Yeah, so this is a very pertaining question. The service providers have clearly told the decontamination inside the equipment is not to be done by the hospital authorities. It has to be done by the service providers themselves. So they will open and they will see to it that it's been done. So this has been done on a regular basis as a part of the preventive maintenance. So the external layer is what need to be taken care by the hospital team.
Okay, understood, sir. Sir, one more question from Dr. Nishant is, which disinfectant cleaning solution or agent do you advise for BME toolkits and test calibrators?
Again, this is something based on the practice of your hospital. We are using sodium hypochlorite solution, but each hospital has a different policies they have to adopt based on that. And more importantly, for the tools, that's not an issue, but for the equipment, even the calibrators, so there is you can refer to the manual of cleaning and disinfection, follow exactly the same practice what has been mentioned.
Okay, sir. Sir, there is one more question, something similar. Can we disinfect the ventilator expiratory cassette which is used for COVID-19 patients? Is it advisable?
We had a discussion with the service provider. So each company has a different way of looking into it. So I would prefer it should be again company specific instruction, do what is being told by the company. Some equipments, they have been in a Sidex solution, the cassette has been taken out and it's been disinfected, but go as per the advice of the service providers. So again, I'm emphasizing cleaning and disinfections, please go as per the advice of the service providers only.
Okay, sir. Sir, one question from Bangladesh, from doctor. Could you please briefly differentiate what is the difference between cleaning and sterilization of a medical device?
As I was telling you earlier, maybe you can refer to the slide which I was mentioning. Cleaning is basically the stains are going to be removed from there. So, so it's not going to kill. So the post-cleaning disinfection is being followed. So you need to understand the difference between the cleaning and disinfection accordingly. And the sterilization is process of killing microorganisms, including vegetative bacteria, viruses, fungi, and bacteriospores. Whereas cleaning is a process of physical removal of the foreign materials like a dust, soil, and organic materials. So you cannot say the cleaning is going to be, if I clean it, that's it. So no, it cannot be. And you cannot do a sterilization of the medical equipment. Medical devices can be sterilized. So there is a difference. Medical equipments are one which needs the maintenance. They need a calibration. Whereas the medical devices, so can be used and you can be sterilized. For example, an instrument is a medical device which can be sterilized, which is basically killing all the microorganisms, including the vegetative bacteria, viruses.
Okay, sir. Okay. Sir, on the similar lines, another question. The cleaning level of the equipments might be different, For example, a instrument might have been used for a COVID suspect, a confirmed COVID, or a normal. How would you make these equipments device clean as per the requirement? Are there special, are there, different criteria to clean the instrument? What actually is trying to ask?
No, there is no. We need to do the same method for every device or the equipment. So we cannot compromise. Okay, this is a non-COVID area, so I will relax. No, it should be same for every device.
Understood, sir. Understood. Sir, Mr. Vasudeva has requested for your opinion. He says, in order to fight or to survive with corona, shortage of healthcare providers and facilities are now exposed. Do we need to create separate department to monitor such an outbreak of pandemic, and special training centers for healthcare professionals, especially biomedical engineers, should be established along with data sciences facility to serve the entire country? Your opinion on it, sir?
I think it's a need of an hour, because a biomedical community is a unfortunately unorganized the community. So we need to have a cohesive approach to the entire issues, and we need to see that the best practices, like what I was sharing, the best practice in our hospital. Similarly, there will be much better practices in other hospitals. So we need to have a one consortium wherein all the best practices are being shared, and it can be circulated to all the other hospitals. The time has come wherein we should not hold the information. The information should be shared, because we are at a stage wherein it's a danger to entire the human life itself. So sooner we learn to share the information and act on it, better for us. And a common platform is a need of an hour.
Correct. Thank you, sir. Actually, sir, there are many more questions. I would just take few more, and then if you don't mind, sir, I can just share your email ID to the delegate so that if any detailed question has to be asked. But I will just take few more if your time permits, sir.
Sure, sure.
Okay. So, sir, one question, Dr. Angelia LH, she is asking, 0.1 micrometer sized nCoV virus floats in the air. So she's asking this without any carriers. Chain break will also be possible only when the individuals are isolated.
Can you repeat the question?
So, sir, what basically she's trying to ask, such a small 0.1 micrometer sized nCoV virus floats in the air, aerosol transmission, so without any carriers. So can the chain break, is it possible to break with, or is it only solution is the individual has to be isolated?
So you can see the picture which I have shown earlier, where in the distance and through which the droplet carriers are happening. So the larger the distance, so the droplets will fall. So the social distance of 1 meter is something which has been based on the problems which have been noticed earlier. So it's, as it's been told, it's a contact based, and it is based on the droplet. It's not air-based transmission. So the distance matters, but not to an extent wherein you are away for a 10 meter and there is going to be transmission.
Understood, sir. Thank you, sir. Sir, few questions related to PPE. You have most of them you have already answered, but still there are some doubts. So one doctor is asking, since PPE are very costly and limited and difficult to find, is there any way or special treatment in which we can sterilize and reuse them? So I think so. You can.
Well, this is also been discussed, and the CDC guidelines has also been seen. So there are there are pros and cons. Like for example, N95. So you have a UV chamber wherein you can keep it for 20 minutes, and then you can sterilize, and 3 times or 5 times you can use it. Similarly, the gown which is being used post usage, so you can keep it on the hanger exposed to the air. Post that, you can go for a ETO and then keep it for a couple of days, and again it can be used. So in this way, the studies have come, but it all depends on our logistic, because there are I was told that there are situations wherein in UK, because of the lack of the PPEs, the healthcare providers got the infection. So conserving the PPE is the need of an hour.
Correct, sir. Thank you. Talking about disinfection and sterilization, can UVC radiation prove superior to OT, ER, and critical care areas? Is it effective as compared to using disinfection solution agent against pathogen like MSRA, VRE, and MDR, GNB?
We recently the ISHRE guidelines, which basically is talking about the air conditioning. So from a the negative isolation area, if the patient is a COVID patient, so there are various ways through which we can kill the virus. One is through a UV, other is maintaining a temperature of 64 degree, or you have the sodium hypochlorite, the solution chamber is there. So there are various ways through which it can be done. So the method need to be adopted by the hospital based on the logistic and based on the infrastructure.
Okay, sir. Sir, one last question. Which is the highest risk generating aerosol procedure amongst ET tube, bronchoscopy, endoscopy, invasive intubation during ventilation?
I'm not a clinician, but what I understand from our clinicians is the intubation is one which need to be a risk is very high. So that's the reason you can see the chamber has been created. So is with the endoscopy procedures. So in the endoscopy again the negative the isolation is been there with the full PPE. The PPE again as you can see in my earlier slides, the full compartment PPE is to be worn in both cases so that the things can be tackled properly.
Okay, sir. In the interest of time, just one last question. Soiled equipment can possess high risk of HAI, healthcare associated infection. We recommend Deepak sir your kind advice and recommendation on the same topic. I think you have already answered, but one small.
See the medical devices I have divided into three categories, which is based on the ECRI. So our disinfection, cleaning and disinfection should be based on the type of the medical device which we are looking at. For example, if there is a blood gas analyzer or a centrifuge where the blood is there, which you can see it, and it is being spilled over the body of the equipment, the disinfection should be stringent. Again, going back to the same, you follow the process which has been set by the infection control or as per the OEM. So same is with the dialysis, where is the second level, wherein the service provider clearly gives what is the chemical to be used, how long it is to be used post the dialysis, and then it should be followed accordingly.
Thank you very much, sir. Once again, I would like to thank you for your valuable time today. The delegates have really benefited from it, and sir, if you don't mind, we would like to keep the recording of this session available for the delegates for a few days. I will just share the recording link on the chat box. So, sir, I hope it is okay. So we can share it with them. The video recording.
Sure.
Thank you, sir. Thank you once again, sir. And once again, thank you to all the delegates to Force Biomedical for arranging such an informative webinar. And we look forward for more such webinars in the coming days. Thank you so much. Thank you all.
Chal rahi.